Assalamu alaikum. This is a male patient aged 54 years old and complaining of right iliac fossa pain. One of the classical cases that you will face in your daily practice, and simply we can see here there is distended appendix measuring about 2 centimeters in diameter, reflecting the formation of the mucocele with multiple air fossae extraluminal around the appendix, and the appendix is surrounded by moderate fat stranding, and the base contain a small ficulus. Somehow you can say this is a classical appendicitis secondary to the ficulus noted at the base, and there is a concealed perforation with inflammatory mass formation around the appendix, and you should mention this in your report. Inflammatory mass formation. The inflammatory mass means there is a thick layer of inflamed fat of the omentum, which is playing the role of the policeman of the abdomen, trying to contain the inflammation around the appendix. Okay, so what is the tricky point? The tricky point here is that the patient aged 55 years old. He lived all his life without getting an appendicitis. So we should search actively on mural lesions at the base of the appendix. We can see here this is the ficulus, and always compare your study. Do a comparison between the non-contrast and the post-contrast images. We can see here there is an avidly enhancing mural nodule noted at the medial wall of the cecum near the base of the appendix. So you should mention this in your report, and it is very important, because if it is just a simple or complicated appendicitis sequel to a ficulus at the base, a specialist surgeon can do the operation. However, if interoperatively they notice a mural lesion at the cecum, the operation will be shifted to a right hemicolectomy, which requires a consultant to do the operation. Also, the post-operative care will be different between a patient who did an appendectomy and the other patient who did a right hemicolectomy. So you should raise the suspicion, because this is a small nodule. I'm not sure truly it is a focal nodule or could be an artifact or something, because it's a small one, intramural. It does not bulge inside the lumen of the cecum like any polyp, but I should mention it in my report and let it to the intraoperative assessment of the whole of the cecum, or doctor may do an colonoscopy to see it before the operation. He will take his suitable action. Okay, in your report it is distended measuring kaza appendix mucocele, where initial hypertensive content is the ficulus, in direction of the cecum, and we should here mention there is a thick layer of fat stranding around the appendix, suggestive of inflammatory mass formation. Okay. By the way, we don't have the post-operative results of this patient, because the patient refused the medical care and left the hospital to seek another health care hospital. يعني ساب المستشفى وراح مستشفى تاني. An intramural gas with fecal loss, focal loss of mucosal integrity at its mid segment with related air fossa in minor collection measuring 5 مللي, indicated a super infection with mild concealed rupture. It is concealed because the air is around the appendix, not free in the abdomen. So there is a super infection of the ventricular mucosa with concealed rupture and inflammatory mass formation, suspected secondary to cecal mural nodule, query for clinical correlation. Okay, so the teaching point here: always actively search for any cecal mural lesions in elderly patient who presented with appendicitis. Okay, good luck.